Welcome to week 3 of our course, in which we are going to describe estimation of costs for economic evaluation in healthcare. The aims are to understand the different components of cost in economic evaluation in healthcare, to differentiate between the terms that are used in cost estimation and analysis in the field, and to differentiate between the different approaches to costing that you will find in papers in the scientific literature. We are going to look at costs in 3 parts, and each part is going to build one on another. So let's start out by cost estimation for healthcare interventions. And just as a recap, last week we talked about the different kinds of economic evaluation: cost consequences, cost minimization, cost effectiveness, cost utility, and cost benefit. And we saw that if you look at it as a numerator-denominator issue, you always have costs on this side, maybe in pounds, in kwachas, Uganda shillings, and on the outcomes you have different metrics. And for cost minimization, there is equivalence of outcomes. For cost utility, you have DALYs or QALYs. If you have dollars, it's cost benefit. And if you have clinical units like life years or millimeters of mercury, this is a CEA, this is a CBA, CUA, CMA. And if you do all of these, or these plus others, then you have a table and just have A and B. Then you list different things, and this is a cost consequences analysis. So let's start out by defining costs. So the opportunity cost is an important concept in economics, and even last week we talked a little bit about opportunity cost being the value of the next best use of resources. And in estimating cost, we seek to approximate the economic cost as much as possible, or the opportunity cost, but this can be quite difficult in practice. And the cost represents the resources used to produce a good or a service. And in healthcare, it includes 2 steps. The estimation of cost includes 2 steps. One is quantifying resource use, and the other one is multiplying by unit cost. So essentially, the cost is equal to the resource use multiplied by the unit cost. Let's now move on to cost categories, and there are 3 cost categories that we use for quantifying healthcare interventions, and these are direct medical or healthcare costs, direct non-medical costs, and indirect costs. Now, direct medical costs, these ones, they go directly into the provision of care, directly for care. So as an example, if a woman came to the maternity suite to deliver, you would consider things like medicine, oxytocin, to be a direct medical cost, midwife time to be a direct medical cost, and maybe you would have something like gloves to perform the delivery. These would be direct medical costs. Direct non-medical costs are costs of resources that are related to the provision of care, but do not go directly into the provision of healthcare. And examples of direct non-medical costs, going on with our example of a woman who goes to the hospital to deliver, include things like her transportation to the hospital, include things like overhead and utilities for the hospital for her delivery, because she's going to need water and electricity to be on in the delivery suite, and other things like that. And then indirect costs are the costs of lost patient productivity. And so while pregnancy is considered to be physiological, maybe she had a complication and she lost a week of work, and it is in two dimensions. Indirect costs are in two dimensions. One is due to illness, and due to illness you'll have things like seeking care, the time lost for seeking care, and for convalescence, that is recovering from care. Seeking care would include, outpatient and inpatient care. And the second dimension is the mortality loss. And this is the costs, the indirect costs of mortality, and this is due to illnesses that cause premature mortality. And the way we judge whether mortality is premature is by indexing on the life expectancy in the specific jurisdiction. So here are the examples. Direct medical, we spoke about personnel, drugs, devices, lab tests, radiological tests, blood products, nursing home costs, hospice costs, home care for people who are being taken care of at home, health education and training. Direct non-medical, you have administration, facilities, overhead, things like equipment, you have electricity and water. Now on the patient side, you have patient travel, including things like parking. You have things like caregiver upkeep, especially in poor countries. If a patient comes with an attendant, that attendant might need lunch, or if they are admitted, they might need to go and hire a small room to be able to take care of a patient for a long time. And there's an important dimension of childcare costs. For adults who have young children and can't leave them by themselves, they incur a cost of childcare. The indirect costs include lost work time when you're visiting the clinic or when you're getting better, after an illness episode. And then there's what we call informal care for the caretaker. And then we have this dimension of premature mortality. The idea that if you die from an illness before your time, quote unquote, based on the average life expectancy of your country, that is a cost associated with the illness. A very important aspect in cost is this idea of the perspective, and it determines the types of resources to include in the analysis. The main perspective is the gold standard perspective, which includes all possible costs, and it's called the societal perspective. And you include direct medical, non-medical, and indirect. The other common one is the healthcare payer perspective, Ministry of Health. In the US, it might be an HMO, maybe Kaiser or Group Health Cooperative. And there are other perspectives like the patient, the physician, the hospital, the clinic, depending on who you're doing the analysis for or what your interest is. A societal perspective is very difficult to do in practice. And sometimes you have people do what they call studies from a modified societal perspective, which means they don't quite include everything, but they try as much as possible to include all the different dimensions of cost. There is a special note that I wanted to make with regards to the cost of a patented medicine. In the numerator of the cost effectiveness ratio, you have the price of the new medicine minus any cost savings. And often these cost savings are called an offset. So this is in the realm of pharmacoeconomics. And it's the idea that a new drug, pharmacoeconomics, and it's the idea that a new drug might lead to cost savings because it reduces maybe the length of hospitalization or the number of outpatient visits. So there's a cost offset. And pharmacoeconomic models focus on estimating this cost offset. And they ask the question, where does the cost offset come from? And what is the cost offset worth? Let's look at this idea of fixed versus variable costs. Variable costs vary depending on the number of patients or individuals targeted by an intervention. And let's say you had in a month 100 HIV patients and you wanted to give them ARVs, you can multiply by the number of doses. That means you need 100 doses of ARVs. If you had devices, you had 10 patients with a fracture of the femur and you want to use intramedullary nails, so you need 10 intramedullary nails. And if you have 2 patients, then you only need 2 intramedullary nails. Same thing with physician. Time to operate these patients, maybe you need an hour on average of surgeon time, and you can multiply this by 10 patients to get 10 hours of surgical time. 10 hours. If you have 3 patients, then you only need 3 hours of the surgeon's time. So depending on the number of patients, then you expend a different amount of cost. Now, for the fixed costs, they don't vary in the short and medium term. So if you have already a hospital and a theater, getting 2 patients versus getting 5 patients versus getting 10 patients doesn't change your building cost. Or if you already bought cars, their cost and maintenance is the same regardless of whether you see 30 people or 100 people. So these costs don't change and they are called fixed costs. And some analysts actually use these terms. That's not a problem really. I mean, if you use them, then it should be both clear and consistent. And that's all that people ask for as you report costs using these alternative terms. The other kind of cost that you will see in some published reports is the idea of intangible costs. And these are to do with things like pain and suffering or fear that are difficult to value directly. But some analysts might use willingness to pay methods. And maybe you'll ask the question, what's your willingness to pay to avoid fear, for example? And this will allow you to put a monetary value on these intangible costs. Remember, we looked at willingness to pay and a cost-benefit analysis and the method of contingent valuation. So it can be used to get at these kinds of costs like intangible costs. So let's move on to cost estimation, and we said that you need to do resource estimation to quantify the amount of resources needed to perform an intervention. And you might do this on a patient-specific basis or a non-patient-specific basis. And it involves 3 steps. Step 1 is to identify the resources. Step number 2 is to measure the resources in their physical units. And physical units just mean if you have personnel, you have hours. If you have medicines, you have doses. If you have like a X-ray, you have the number of X-rays performed or the number of scans performed. And then the third step is to value these resources, which essentially means assigning the unit cost. So these are the 3 steps of estimating cost. The 2 main approaches to estimating cost are gross and micro costing. And gross costing is also called top-down costing, and micro costing is called bottom-up costing. In gross costing, an analyst views resources in bundles. So you must say, what is the cost of a hospital day following surgery for fracture of the femur, or surgery following, let's say, an evacuation for a septic abortion or something like that. Now, that's different from micro costing, in which you identify the values of all the resources that are used during that day. For example, you might say, well, in this day there were 30 minutes of physician time, 2 bandages, 10 doses of pain medication, and 4 bottles of IV fluids. And then you would assign a resource amount. After assigning the resource amount, you would then assign a unit cost. So resource times unit cost, and you would get the cost. Now, the choice of gross or micro costing depends on the data availability and the ease of data collection. And some studies actually use both approaches. And in some cases, one is preferred over the other. An example is if you have a labor-intensive intervention, like maybe hemodialysis, and you're comparing that to peritoneal dialysis, which is ambulatory and continuous, if you use gross costing, you might underestimate the personnel time differences, because it will give you a cost of dialysis in general. But you really want to capture the personnel differences, because one of them, which is ambulatory, has no heavy personnel involvement, which is the ambulatory peritoneal dialysis. But the hemodialysis is very dependent on clinicians to essentially execute. So it might be better in that case to use a micro-costing approach. Many studies in the literature actually use micro-costing, but it's important to say that I think that the gross costing approach is a little bit closer to opportunity cost, because it's more reflective of the actual amount of money spent on providing healthcare interventions. So let's look at step one of doing cost estimation, and this step is identification. In the identification stage, an analyst estimates the different resources required, and that estimation depends on the perspective. Like we said, there is the societal perspective, and maybe you have a payer, and in many countries the payer is the Ministry of Health. So that is the one that guides essentially your identification stage. And the analyst needs clinical knowledge of the intervention. And usually even non-physicians can do cost effectiveness analysis, but it would be good to collaborate with a clinician who knows the disease area well. And resource identification also depends on the approach, whether you're doing a gross or a micro costing. Then during measurement, essentially it also depends on context, whether in a trial or in routine care. In a trial, all you need to do is go to the CRF. This is the case report form. For those of you who have participated in trials, there is a form called the case report form, or the CRF, and this CRF will give you everything that the patient has received in lieu of medications, of doctor follow-up, of nurse follow-up, and you can use that to estimate resource quantities. In routine clinical situations, you need to go and read the case notes or to get the records. Now, in my experience using records in low and middle income countries, some of them are really bad. So you have a file from a patient and you can't even accurately get a handle on the drugs that were given, the surgeries that were performed. But sometimes you can actually find exactly what resources were consumed by looking at records. Sometimes it's necessary to perform direct measurements, and you can use a questionnaire. And I am fond of time motion surveys to quantify health worker time. I showed you an example of a time motion survey during the last week, in which we measured personnel time use in a cost minimization analysis of HIV care. And you can also do direct observation to be able to quantify resource use. Next, we go to valuation. It involves the assignment of unit costs, and unit costs should also be as close to opportunity cost as possible. When market prices are available, then this is a good thing because they approach opportunity cost, and you might find some of them in publicly available sources like the MSF drug price indicator. This should be drug price and not price drug indicator. Price catalogs in countries or salary scales, and prices including excess profit don't usually reflect societal opportunity costs, so you need to adjust them. And in the US, there's an adjustment called a cost to charge ratio. So the bill in the hospital will say maybe for a hospital day it's $10,000, but the insurance company will pay the hospital maybe $5,000. And you can get at this by adjusting using the cost charge ratio. Sometimes market prices are not available, but you can use what they call a shadow price, which means a price of a similar product to get at the price of the product for which you want to perform a valuation. In high income countries, you have healthcare tariffs and charges, and you have some databases like the DRG payments for Medicare services. And so you can use those to estimate cost. Sometimes you need to do primary data collection in the context of trials, and even in other contexts like doing administrator surveys or market surveys to get at some of the unit costs that you might need in your individual study. But really, valuation is about assigning a unit cost to the different resources that you estimated in the estimation phase and you identified in the identification phase. So here's an example, rather stylized, of a costing exercise. We have been asked essentially to estimate the cost of managing fractures of the femur shaft at a local hospital. We have two main methods. For those of you who are physicians, you know that even to today, in some hospitals, they still use traction to manage medullary femoral fractures, fractures of the femoral shaft, which is this bone right here. And the reason that we make a difference between the shaft and other parts of the bone is that when the fracture is right here at the knee, it's very complex to manage, and when it's at the neck of the femur, usually involves the pelvis, it's also a different kettle of fish to manage. But there are two approaches. This is the traction method. People are going to stay in the hospital for months and immobilized, and there are many complications like bed sores and other things. And then you can do surgery, which is very efficient, but it might be more expensive, in which you get this pin, essentially, this nail, an intermedullary nail, and you fix the fracture under general anesthesia in an operation. And it's essentially the advantage is that it heals much quicker and you can restore function much quicker. So let's use this example to see what happens in a costing exercise. So we might set out some assumptions, and in economic evaluations, it's usually very, very good to set out your assumptions clearly at the beginning so people can know what you did. And we'll look at this especially when we look at modeling, in which it's really important to set out your assumptions and say that this is what I assumed. So in this example, we can assume that we are doing per patient costs, and we would also like to use micro costing as opposed to top-down costing, and that our perspective is the payer. Maybe this payer is the Ministry of Health of a country like Tanzania. And every time I use countries, I'm not picking on any one country. It's just for strictly pedagogical reasons. So we might use Microsoft Excel, and this is an Excel spreadsheet, and I can actually make this easy Excel spreadsheet available to you. But you have this column here with a patient ID, and we have 10 patients. And just for convenience, we have 5 patients who have traction and 5 patients who have internal fixation. And that second column is an identifier for traction or no traction. So traction is 0 and 1 is internal fixation. So patient number 1 had traction, number 2 traction, number 3 internal fixation, number 4 internal fixation, and so on. And then in the columns you have resources. You have x-rays, lab tests, doses of painkillers, antibiotics. You have doctors and nurses time, and you have the device. This is the intramedullary nail that you're going to use for internal fixation, and you'll see that for those who have traction, there's no cost for that. There's no resource use for that. But for those who have internal fixation, you have that they need these nails essentially. And then for surgeon hours, you have the different numbers of hours for the different patients, and it depends on the individual patient. I mean, clinicians are trained to look at the individual, but when we do analysis, we're interested in the average. So the average number of hours would be all these added divided by 10. And we'll look at the average in the next slide. But you also have hospital days, which are also dependent on severity, essentially. People who have complications may spend a long time. So maybe this patient who had traction stayed 90 days in the hospital, and so on, basically. So now you need to estimate the unit costs. Let's say that an X-ray costs $5. Painkillers cost just $1. The doctor is $40 per hour, and so on and so forth. And you need to multiply these unit costs by the resource use that we set out in the previous slide. So here's the updated cost database, and all we have done is to multiply the resource use by the unit cost. So we have taken the resource use 2 slides ago and multiplied by the unit cost, and for each patient. This is per patient. So this is what we call a cost database. And in the last column is just a summation of the costs per patient. And you can use that to calculate the average cost per patient, which is here. And you can do this for patients who are on traction and patients who are on internal fixation. And essentially, if you were doing the incremental cost, it would be 11,990.5 minus $4,679. This would be the incremental cost. So your numerator is actually taken care of. If you're doing a cost utility analysis, maybe you would have maybe the QALYs for traction minus the QALYs for internal fixation. And here you have traction. So you would be able to do a cost effectiveness analysis. And with this cost database, you can do many different kinds of calculations. You can do the difference in X-ray costs. You can do the difference in lab test costs. You can see the difference in the number of physician costs. You can see the difference in device costs. And you can also look at the total cost per category. So you can do analysis on these, and you can do different things to the numbers. But it's important to create this cost database when you're doing an actual analysis. So with that, I would like to stop this part 1 of week 3, and in the next part, in part 2 of week 3, we're going to continue with cost estimation for healthcare interventions. So see you in part 2 of week 3. Thank you very much.